Hello again. Welcome back to Emergency Medical Responder. This is Chapter 7 covering airway management. All right, so the two most important life-saving skills is airway care and rescue breathing. As a first responder, you're going to need to be very prolific in each one of these. These are very, very important because patients must have an open airway and must maintain adequate breathing to survive. By using these simple skills, or some simple skills that you're going to learn, you can often make a difference between life and death. Is what we call the ABCs of life-saving skills. A stands for airway, B stands for breathing, and C stands for circulation. Remember the check and correct process for both airway and breathing skills. All right, so to maintain life, all humans must have food, water, and oxygen. The lack of oxygen, even for a few minutes, can result in irreversible brain damage and death. If brain cells are deprived of oxygen and nutrients for about 4 to 6 minutes, they begin to die. Brain death is followed by the death of the entire body. The main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells as they pass to the lungs. All right, so in this particular diagram, it shows you the different components of the parts of the body that's used for breathing. The mouth, which is we refer to as the oropharynx, the nose, which we refer to as the nasopharynx, then the throat, and trachea or windpipe, the lungs, and then the diaphragm, which is a dome-shaped muscle between the chest and the abdomen. And there are numerous chest muscles that also support it. So this in particular figure shows you a good breakdown in the different locations of all of the airway components. All right, so in an unconscious patient lying on his or her back, the passage of the air through both the nose and mouth may be blocked by the tongue. The tongue is attached to the lower jaw, or what we refer to as the mandible, if you remember that back during the anatomy and physiology lecture. What happens is that this creates a partially blocked airway and often produces a snoring sound. This is a figure showing the representation of an unconscious patient. You can see where the airway could be blocked by the tongue. That particular diagram on your left, that big old fat tongue, when the patient's unconscious, it falls on the back of the throat. On the right side, it shows you a conscious patient where they're able to continuously lift up the tongue and keep their airway open. So it's important to recognize that and to be thinking about it. All right, so other parts of the respiratory system, the first part is at the back of the throat. There are two passages. You have the esophagus. This is the tube in which food passes through. And then you have the trachea. The trachea is where your oxygenation, every time you breathe in and out, supply your lungs with oxygen. All right, the epiglottis is a thin flapper type of valve that allows the air to enter the trachea but helps prevent food or water from entering the airway. Below the trachea is where the airway divides into the bronchi. You have two large tubes that are supported by cartilage. That's what bronchi are. The lungs are located on either side of the heart and are protected by the sternum in the front of the body and by the rib cage at the sides and the back. Other parts of the respiratory system also include the smaller airways that branch down from the bronchi. They call those bronchioles. The bronchioles end as tiny little air sacs where that oxygen exchange happens. Those are called alveoli. That's where that actual exchange of gas takes place across what we call thin membranes, or semi-permeable membranes that separates the capillaries of the circulatory system from the alveoli in the lungs. The exchange of oxygen and carbon dioxide that occurs in the alveoli is called alveolar ventilation, and it occurs through a process that we call diffusion. The amount of air pulled into the lungs and removed from the lungs in 1 minute is what we call minute ventilation. When the patient is not breathing, artificial ventilations are necessary to supply oxygen to the heart and the rest of the body. All right, so this is a great diagram, and you'll find this in your book. It talks about the exchange of gases that occur within the alveoli of the lungs. You can see a good representation here when you look closely. It gives you a section 1 where deoxygenated blood is carried from the heart to the lungs by the pulmonary arteries and by the arterioles. And you can see that deoxygenated blood. Here it comes. See the arrow right here? It comes to the alveoli, okay? And because of the change of partial pressures, there's a gas exchange that happens here. The CO2, okay, is able to come back into the alveoli so it can be exhaled. And then the oxygen, as you see right here, it goes into the capillary wall, and then getting new oxygen or replacing, the CO2 with new oxygen so it can be pumped back through the body. So that's where that gas exchange takes place. It takes place at the capillaries covering those alveoli. And then thirdly, right here, the oxygenated blood is carried from the lungs to the heart by the pulmonary veins and the venules, and then spread out through the bodies or the body cells when the left ventricle pumps it out through the aorta. All right, so the lungs consist of soft, spongy tissues with no muscles. Movement of the air into the lungs depends on the movement of the rib cage and the diaphragm. When the diaphragm contracts during inhalation, it flattens out and moves downward. On exhalation, the diaphragm relaxes and once again becomes dome-shaped. Here's a good representation of normal mechanical active breathing. The left is inhalation and the right is exhalation. All right, so the A is for airway. A is for airway. In healthy individuals, the airway automatically stays open. In seriously injured or seriously ill patients, they may not be able to protect their own airways, so it may become blocked. You must check the condition of the patient's airway and correct any problem to keep the patient alive. All right, so how do we do that? First thing we do is we check for responsiveness. Hey, are you okay? Determine whether the patient is responsive by asking that, okay? You need to shout and tap them and ask that. If you get a response, you can assume that the patient is conscious and has an open airway. If there is no response, gently shake the patient's shoulder and repeat your questions. This figure shows you how to do that. Notice that this patient is laying on their left side, which helps them to keep their airway, semi-open. We'll talk about that later, called the recovery position. All right, so if the patient is still unresponsive, call 911 first before doing anything else for the patient. After call 911, position the patient by supporting the patient's head and neck and placing the patient on his or her back. Now that we've got them on their back, we're going to see if the airway is blocked. So an unconscious patient's airway is often blocked because the tongue has dropped in the back and is obstructing it. So simply opening the airway may enable the patient to breathe spontaneously. We perform what's called the head tilt chin lift maneuver. Place the patient on their back and kneel beside the patient. Place one hand on the patient's forehead and apply firm pressure with a backward presentation with your palm. Place the tips of the fingertips on your other hand under the bony part of the lower jaw, near the chin. Lift the chin forward to help tilt the head back. And in this figure, you can see how this works. You're going to tilt the head back, lift up on the chin, and the airway should open. All right, so jaw thrust maneuver. This is a technique that's used if you suspect a spinal or neck injury. Place the patient on his or her back and kneel at the top of the patient's head. Once your fingers are behind the angles of the patient's lower jaw, and move the jaw forward with firm pressure. Tilt the head backward to a neutral or slight sniffing position. Use your thumbs to pull down the patient's lower jaw and open the mouth enough to allow for breathing through the mouth and nose. All right, so in this figure, it shows you the jaw thrust maneuver, and it should open the patient's airway without extending the neck. As you can see on the left side, kneeling above the patient's head, place your fingers behind the angles of the lower jaw and move the jaw upward. And use your thumbs to help position the lower jaw on the right-hand side to complete the maneuver to keep the airway open. It should look just like this. All right, so once you've opened the mouth, you want to check for any blocks. Check for fluids, foreign bodies, or dentures. After you've opened the patient's airway, look inside, okay? Those potential blocks include secretions such as vomitus, mucus, or blood, foreign objects such as candy, food, or dirt, or dentures or false teeth. If you find anything in the patient's mouth, remove it. If the patient's mouth is clear, consider using one of the devices as described in the section on airway devices. All right, so correct the airway using finger sweeps or suction. Never blindly do this, only if you can see it. You'll be clearing out vomitus, mucus, blood, and foreign objects, and it must be cleared from the patient's airway. Again, those finger sweeps, they can be done quickly and require no special equipment except for a set of medical gloves. To perform finger sweeps, follow the steps in your skill drill 7-1. And finally, suctioning. Suction machines can be helpful in removing secretions such as vomitus, blood, and mucus from the patient's mouth. Right, so manual suction devices. These suctions are relatively inexpensive and compact enough to fit in your emergency medical responder life support kit. Insert the end of the suction tip into the patient's mouth and squeeze or pump the hand-powered pump. As you can see, this is a figure over here of the hand-powered pump. Very simple kind of device. It's got a little bulb on it. You're going to squeeze and suck, and it comes into the contents of the mouth will go into this bag. Right, so other mechanical type of devices, not portable or manual ones, mechanical devices, they use either a battery-powered pump or oxygen-powered aspirator to create a vacuum. Such a device draws the obstructing materials from the patient's airway. So you're going to clear the patient's mouth with large pieces of material with your gloved finger, and then turn on the suction device and use the rigid tip to remove most of the remaining material. Do not suction for more than 15 seconds at a time because the suction also draws air out of the patient's airway. Make sure to change the flexible tip and clear out any material from the deeper parts of the patient's throat. Okay, here's an example. This photograph here shows a battery-powered suction device. All right, so maintaining the airway. For unconscious patients, continue holding the head to maintain the head tilt or chin lift or jaw thrust position. If the patient is breathing adequately, place him or her in the recovery position. You can also insert an oral or nasal airway to keep the patient's airway open. All right, so the recovery position. If an unconscious patient is breathing, the patient is not suffering from trauma, place the patient in a recovery position. The recovery position helps keep the patient's airway open by allowing secretions to drain out of the mouth instead of draining into the trachea. It also uses gravity to help to keep the patient's tongue and lower jaw from blocking the airway. This is an example of the recovery position. To place them in that position, as you can see here, you roll the patient on one side as you support the head, and then place the patient's face on his or her side so any secretions can drain out of the mouth. All right, some oral airway adjuncts. We do use things that we call oral airways that we put into the mouth. They have two primary purposes. First is to maintain the patient's airway, and the second is to function as a pathway for suctioning. We use most of these for unconscious patients who are breathing, that are in respiratory arrest, or also do not have a gag reflex. These are oropharyngeal airways. They're just two different brands, as you see on this particular figure. The oral airway. These airways can be used with mechanical breathing devices such as a pocket mask or a bag valve mask. There are two styles of oral airways. One style has an opening down the center. The other has a slot along each side. Before you insert the airway, you need to select the proper size. Choose the proper size by measuring from the earlobe to the corner of the patient's mouth. Follow the steps in the skill drill 7-2 to insert the oral airway. You need to remember, oral airways, if we're going to put these in, these patients cannot have a gag reflex. So just an FYI, if you have a conscious patient, this is not going to work for you. All right, so this is the nasal airway. Here's three different sizes. They're made from a rubber-like material, latex material. They're used in both unconscious and conscious patients who are not able to maintain their own open airway. It's not as likely to cause any vomiting. You can also suction right through the center of them. It's just a tube that you're going to insert in the nose. Okay. So how do we do this? First thing you need to do is you need to select the proper size. You measure from the earlobe to the tip of the patient's nose. Coat the airway with a water-soluble type of lubricant. The airway is then fully inserted with the flange of the trumpet rest against the patient's nostril. And you can use skill drill 7-3 to practice this particular skill. All right, B is for breathing. You can use the look, listen, and feel technique to assess adequacy of breathing. Patients have to be breathing. Even though the A is the airway part, that's just to get it open. Okay, you got to have an open airway to be able to breathe. The next item is, are they breathing? So you got to look for the rise and fall of the patient's chest, listen for sounds of air passing into and out of the patient's mouth or nose, and then you can feel down there to see if there's any air moving on the side of your face or on your hand. Normal adults have a resting breathing rate of somewhere between 12 and 20 per minute. All right, so signs of inadequate breathing. One of the great anesthesiologists that I worked with always told me, said, Jeff, the patient's respirations that are normal, they're silent. Okay, so normal respirations are silent. So noisy respirations or wheezing or gurgling, that's a problem, and you're going to have to do something about it. Same thing with rapid or gasped respiration, or if the patient is pale or has a bluish tint to the color of their skin. The most critical sign is respiratory arrest, which is characterized by the lack of chest movements, lack of breath sounds, or lack of air against the side of your face or your hand. All right, so some of the common causes of respiratory arrest could be heart attacks, could be a blockage of the airway, could be vomitus, especially in a patient weakened by a condition such as stroke, or any foreign object, or a sudden onset of an illness or disease. Other causes: drug overdose, poisoning, severe blood loss, or electrocution by some electrical current, or perhaps even lightning that came from the sky. All right, so next year, as far as checking for presence of breathing, your assessment of any motionless patient begins by checking for responsiveness and then assessing for breathing. If the patient is responsive in breathing, assist him or her as needed. However, if the patient is unresponsive, you need to determine if the patient requires assistance with breathing or other intervention. While checking to see if the patient is responsive, look for signs of breathing by visualizing the patient's chest and observing for any visible patient body movement. All right, so correction. To correct the breathing problem, as you perform rescue breathing, keep the patient's airway open by using the head tilt chin lift maneuver or the jaw thrust maneuver, whichever one. Be sure to pinch the patient's nose with your thumb and forefinger. Take a deep breath and blow slowly into the patient's mouth through a mask, okay, mask seal with a valve, for 1 second. Remove your mouth from the mask and allow the patient's lungs to deflate. Breathe for the patient a second time, okay? After these first 2 breaths, breathe once into the patient's mouth every 5 to 6 seconds. So this is rescue breathing. If you find a patient that's unconscious and unresponsive, they have a pulse, but they're not breathing, we're going to perform this procedure. So 1 breath every 5 to 6 seconds. Here you go. This is that mask we were talking about that has a valve on it, that one-way valve. This is mouth-to-mask rescue, and that enables you to perform rescue breathing without mouth-to-mouth contact. And therefore, it reduces the risk of transmitting infectious diseases, and there's a skill drill for that you can perform as well. All right, so mouth-to-barrier rescue breathing devices are small enough to carry in your pocket. They're very, very easy. It could be a mask or a plastic film, that kind of stuff, and they provide variable degrees for infection control. Using the mouth-to-barrier rescue technique is in skill drill 7-5. All right, so correcting the breathing, the mouth-to-mouth rescue breathing, although not recommended for patients that are unknown patients, it is still the best method for you to get an adequate seal. So if it's your loved one, your child, those kind of things, I'm sure you wouldn't mind doing it. It requires no equipment. It does carry a somewhat higher risk, obviously, if you're doing on somebody you don't know or a stranger, of contracting a disease, but it still is the best way to get a good solid seal to ventilate somebody. All right, so the bag valve mask or BVM, it is a device that we use. We place that mask over the patient over the face to get a tight seal, and we squeeze the bag, and that bag pushes air, through a one-way valve through the mask and into the patient's mouth and nose. As the patient exhales, there's another one-way valve that releases the air. This is a good photograph showing you a bag valve mask. Notice that there's two people that are doing this. You have one person that's holding the mask and one person that's squeezing the bag. That's probably the best way, especially for first responders. I haven't done this very often. It's very difficult to get a seal on somebody and to get the airway open. So two people is what's recommended. All right, so airway and breathing. Okay, so airway and breathing review. You should assume that all patients may be in respiratory arrest until you can assess them and determine whether they are breathing adequately. All right, so the airway, you're checking for responsiveness, remember, by shouting, hey, hey, are you okay? You gently shake the patient's shoulder. If the patient is unresponsive and the EMS system has not been notified, you have to activate the system. You've got to get EMS on their way. Place the patient on his or her back. Correct a blocked airway by using the head tilt chin lift maneuver or the jaw thrust maneuver. Then check in the mouth for any secretions, vomiting, or solid object. If found, clear the mouth. Correct a blocked airway if needed by using finger sweeps or suction, and remove any foreign substances. Then maintain the oral airway by manually holding it open or by using an oral or nasal airway. And then finally, you're looking for breathing. Okay, check for the presence of breathing. Correct the lack of breathing by performing rescue breaths using a mouth-to-mask or mouth-to-mouth barrier available. So that is the review of airway and breathing. Very simple stuff to do. All right, so performing rescue breathing on children and infants, slightly different. Rescue breathing for children and infants are slightly different because children are smaller and you will not have to use as much force to open the airway or tilt their heads. The rate of rescue breathing is slightly faster for children. So you're going to give one breath every 3 to 5 seconds, which equals about 12 to 20 rescue breaths per minute. Rescue breathing for infants. An infant is tiny and must be treated extremely gently. The steps in the rescue can be found in skill drill -7, but the point is you're going to barely tilt the head back and you're still going to give them one breath every 3 to 5 seconds, just enough to see chest rise. Right, so foreign objects in children, causes of airway obstruction. The most common airway obstruction is the tongue. So with children and adults, it is most common. If the tongue is blocking the airway, again, by tilting the head back or doing jaw thrusts, you're going to do that. Food is the most common foreign object, period, that causes airway obstructions. The foreign body is usually lodged in the air passage, so you got to do a technique to get the particular item out. All right, so here's an example showing the blockage of the airway, tongue blockage, injury, swelling, and then finally foreign object. A couple of diagrams there for you. All right, so types of airway obstruction, and what do you do about it? Ask the patient, are you choking? If the patient can reply, the airway is not completely blocked. There's still some movement of air. If the patient cannot speak or cough, the airway is completely blocked. So you need to know that. Either you have a partial obstruction or a complete obstruction. If it's a partial and it's what we call a mild airway obstruction, the patient coughs or gags, then just encourage them to keep coughing. If they can speak and make noise, just have them cough whatever the item is up. Encourage them over and over again. If they cannot expel the object, then arrange for prompt transport. Right, in a severe airway obstruction, this is where the patient's unable to breathe in or out and the speech is not possible. Other symptoms may include poor air exchange, increased difficulty breathing, a silent kind of cough, or loss of consciousness within the first 3 to 4 minutes. Treatment involves what we call abdominal thrust. So this is a patient that's still conscious, and you're going to do abdominal thrust on them to get it out. If the patient is conscious, stand behind him or her and perform the abdominal thrust. The skill drill is 7-8, and it's really simple to perform. We call this the Heimlich maneuver. If they become unresponsive, then you're going to perform cardiopulmonary resuscitation, or CPR. Right, so in the airway obstruction of a child, tilt the head back just past the neutral position. If the child becomes unresponsive, again, we're going to provide CPR for 5 cycles before activating the EMS system. But that air obstruction is usually very simply to relieve. When you have somebody who's coughing, a child, it's if you can hear noise, so you could still hear the infant or the child making noise, then they're going to be able to probably cough that up themselves. If it's an infant, okay, the infant, if they have an audible type of cry, the airway is not always obstructed, so we can do something about that. Go ahead and use a combination of back slaps and chest thrusts in order to get it dislodged from the infant. If the infant becomes unresponsive, ensure that the EMS system has been activated. Begin CPR and continue CPR until a more advanced EMS personnel arrive. All right, oxygen equipment. Oxygen cylinders. Oxygen is compressed to 2,000 psi and stored in portable cylinders. The portable oxygen cylinders used by most EMS systems are called either a D or an E size. Depending on the flow rate, each cylinder should last for at least 20 minutes. The pressure regulator and flow meter, that's what this guy is right here. Okay, that is the regulator and flow meter. It is a single unit that's attached to the outlet of the cylinder. It can be adjusted to deliver oxygen at a rate of 2 to 15 liters per minute. So what that regulator does, it takes that 2,000 psi and brings them down to about 60 or 80 psi, so it can be flowed out at different liter flows. There's a gasket in there you need to make sure that you replace every time you change out the bottle. All right, so continue on some airway adjuncts, nasal cannulas and face masks. What they do is they ensure that oxygen is delivered to the patient and it's not lost off into the air. Nasal cannulas are used to deliver medium concentrations of oxygen, and the face mask is placed over the patient's nose and mouth to deliver a higher concentration. Non-rebreathers are most commonly used by EMRs, and they deliver the highest amount of oxygen that you can give in the field. All right, some safety consideration. Oxygen actively supports combustion and can quickly turn a small spark or a flame into a serious fire. So it's not a flammable gas, but what it does is it accelerates any flame that's around it. So all sparks, heat, flames, and oily substances must be kept away. The pressure in an oxygen cylinder can also cause an explosion if it's damaged. So oxygen cylinders should be kept inside a sturdy carrying case and always in a locked position whenever they're in the ambulance. All right, so administration of supplemental oxygen, how we put the flow regulator into service. Place the regulator flow meter over the stem of the oxygen cylinder and line up the pins in the pin indexing system. Tighten it down by securing the screw firmly by hand and then turn the cylinder valve 2 counterclockwise turns. All right, so check the gauge on the pressure gauge flow meter. Make sure that it reads at least 2,000 psi. And then once you begin to open up or adjust the flow meter, you will be using that to deliver the desired liter per minute flow. When the oxygen flow begins, place the face mask or nasal cannula onto the patient's face. Here's your nasal cannula, right? It delivers low flow oxygen at 1 to 6 liters per minute and in a concentration of 24 to 44%. You'll adjust the liter flow to 1 to 6 liters and then apply the cannula to the patient. Here's your non-rebreathing mask. And when we talk about non-rebreathing masks, the caveat to this is it has this plastic bag on it. It's used to deliver a high flow concentration of oxygen at 8 to 15 liters per minute. It can deliver concentrations of oxygen as high as 90%. Non-rebreather mask continued. It should be used for patients who require those higher flows of oxygen, such as a patient who's short of breath, severe chest pain, carbon monoxide poisoning, or congestive heart failures, or signs and symptoms of shock. Right, so hazards of supplemental oxygen. Supplemental oxygen must be used carefully so that you and your team and the patient will remain safe. You will need additional classwork and practical training before you're ready to administer oxygen, especially in emergency situations. That's what your skill drills are for. All right, so let's talk a little bit about pulse oximetry, where we can learn a lot about our patients and their conditions. Pulse oximetry is used to assess the amount of oxygen saturated in the red blood cells. It is a machine that performs this function, okay? We call it pulse oximeters. A pulse oximeter consists of a sensor, probe, and monitor. To operate the pulse oximeter, simply turn on the monitor. Once you know the monitor is operating correctly, place a sensor probe over the patient's fingertip or earlobe. The monitor should then display the percentage of saturation of the patient's blood. It will also give you a pulse rate as well. All right, so in a healthy patient, the oxygen saturation should be between 95% and 100 when breathing room air. If a patient has difficulty breathing as a result of injury or disease process, the percent of oxygen saturation may be much lower than 95%. Pulse oximetry cannot tell you what's wrong with the patient, but it can help you and give you some guidelines. Recognizing that the patient's having a problem, it also may give you some information to determine whether you're going to treatment with oxygen is going to be helpful or not. Any patient that's below 94% on oxygen saturation should receive oxygen. All right, it does have limitations. It will not give an accurate reading if the patient's wearing nail polish, if they're cold, if they've lost a lot of blood, or they've experienced a carbon monoxide type of poisoning. There is no machine, though, that can replace careful patient assessment. So don't rely upon that machine or others. Do your good assessment. All right, so special consideration. Rescue breathing for some patients with stomas. If they have a stoma, this is where some people have had surgery that's removed part or all of the larynx. In these patients, the upper airway has been rerouted to open through a stoma or a hole in the neck. So rescue breathing can be, rather touchy. It must be given through the stoma in a technique that's known as mouth-to-stoma breathing. Obviously, we're going to use a mask of some sorts. Check every patient for the presence of a stoma. If you locate one, keep the patient's neck straight. Examine the stoma and make sure that you clean away any mucus that's in it. And if there's a breathing tube in the opening, remove it, make sure that it's clear. All right, so next thing you do is that you can place your mouth or a mask over the stoma. I would not use the same thing as mouth-to-mouth breathing. You're going to have to make sure that you have some kind of barrier device because there's a lot of secretions in this area. If the patient does not rise, if the patient's chest does not rise, then seal the mouth and nose with one hand and then breathe through the stoma. A bag valve mask or pocket mask device can also be used to ventilate the patient through the stoma. All right, so gastric distension. This occurs when air is forced into the stomach instead of the lungs. Okay, it increases the chance that the patient will vomit, so we need to try to get that air out. And even preventing the air from getting in to begin with. So breathe slowly into the patient's mouth, just enough to make the chest rise. So when we're ventilating somebody, you want to make sure the airway is open, effectively, and then breathe through the mouth. All right, so do not remove any dental appliances that are firmly attached. If they're not loose in the back of the throat, they're actually going to help you maintain a seal when you're using your bag valve mask. All right, so airway management in a vehicle. Sometimes you may have somebody that's trapped in a vehicle that you have to manage their airway. Use the jaw thrust maneuver if the patient's lying on the floor of the seat, or if there's any possibility that a crash could have caused a head or spinal injury. When a patient is in a sitting or semi-reclining position, approach the patient from the side by leaning through the window or across the seat itself. Grasp the patient's head with both hands. Put one hand over the patient's chin and the other hand over the back of the patient's head. Maintain a slight upward pressure to support the head and cervical spine. Here's a good example of it where it says on the left side to open the airway, place one hand under the chin and the other hand on the back of the patient's head. And then on the right side, as you can see, raise the head into a neutral position. So this is raising the head in a neutral position. And there you are putting your hand inside. Right, so this technique has several advantages. You do not have to enter the automobile. You can easily monitor the patient's carotid pulse and breathing patterns by using your fingers. This technique also stabilizes the patient's cervical spine and opens the patient's airway. All right, so summary on this chapter. The main purpose of the respiratory system is to provide oxygen and remove carbon dioxide from the red blood cells as they pass to the lungs. The structures of the respiratory system in children and infants are smaller than the corresponding structures in adults. And then as a consequence, the air passages of children and infants may be more blocked in by secretions and foreign objects. When a patient experiences the possible respiratory arrest, we need to check for their unresponsiveness. Open the blocked airway using the head tilt, chin lift, or jaw thrust maneuver. Check for fluids, solids, and dentures in the mouth, and correct the airway if needed. And also you can use your finger sweeps or your suction to get anything out of the mouth. Also, we need to maintain the airway by continuing to manually hold the airway open by placing the patient in a recovery position or by inserting an oral or nasal airway. And then if the airway is obstructed in a conscious adult or child, kneel or stand behind the patient and perform the Heimlich maneuver. And finally, administering supplemental oxygen is a part of an EMR responsibility if you're carrying oxygen. So anybody who's showing signs and symptoms of shock increases the amount of oxygen delivered to the cells. So therefore, it's a good idea to give them oxygen if you have it. Pulse oximetry is used for assessing the amount of oxygen saturated in the red blood cells. All right, folks, that's it for this chapter. Congratulations again for getting this lecture done. Go on back to your JBL Navigate dashboard, go to the assessment block, open the chapter assessment for the lecture, and complete the assessment, and then hit the button that says submit. You may take those assessments as many times as you like, and you must achieve a 70% or higher cumulative score for each chapter. All right, with that, if there's any questions, again, thank you for your participation in the program. If you have those questions, go ahead and email them to us. Your instructor will respond to you as soon as possible, usually within 48 hours. Your email address to send it to is student@emets.net. All right, folks, have a great day, and we'll see you next time.